All right. Well, good morning, everyone, and thank you for joining us today. Before I turn things over to our speakers, please know that we'll be setting aside some time at the end of today's discussion for audience questions. If you have a question for any of our speakers, please use the Q&A button to type your question into the box that appears at any time. Please make sure that you include your name and organization with your question so that we can identify you for our speakers. Now, to get us started, I'd like to introduce Marie Williams, Stoneleigh Foundation's Deputy Director and the moderator for today's event. Marie.
Thank you, Mark. Good morning, everyone. On behalf of the Stoneleigh Foundation, I'd like to welcome you to today's webinar entitled Healing Hurt People, Hospital and Community-Based Violence Intervention. As Mark mentioned, my name is Marie Williams, and I'm Deputy Director of the Stoneleigh Foundation and the moderator for this morning's event. For those of you who are not familiar with Stoneleigh, we're a Philadelphia-based foundation that awards fellowships to exceptional leaders who work within, alongside, and outside of systems of care in order to improve the life outcomes of young people and families. Before we begin, though, I'd like to offer some context for today's conversation. According to the most recently available data, the top 3 causes of death among our young people are unintentional injuries, accidents, homicide, and suicide. But for every 1 young person who dies as a result of their injury, there are roughly 30 who survive and require continued care to come to terms with their injuries physically, emotionally, and psychologically. Fortunately, mental and behavioral health has evolved in no small part due to some of our panelists today to recognize that children and young adults who are violently injured must be treated in a way that is trauma-focused and developmentally appropriate. Today, our panelists will discuss the growing recognition that many of the therapeutic approaches developed over time, like trauma-focused cognitive behavioral therapy, TF-CBT, are adaptable to a changing treatment landscape, and they can be adhered to outside of a hospital or the clinical setting, and also utilizing community health workers who are peers to the young people being treated. To discuss this evolution and how it's played out at Healing Hurt People, a hospital-based violence intervention program at Drexel University's Dornsife School of Public Health, I'm joined by Dr. Ted Corbin, a former Stoneleigh Fellow, co-founder of the Healing Hurt People program, and chair of the Department of Emergency Medicine at Rush University Medical Center in Chicago. Welcome, Ted. Arturo Zinni, a current Stoneleigh Fellow and Assistant Clinical Professor and Executive Director of the Center for Nonviolence and Social Justice at Drexel University's Dornsife School of Public Health. Also, Dr. Judith Cohen, the co-developer of trauma-focused cognitive behavioral therapy, a professor of psychiatry at Drexel University's College of Medicine, and the medical director of the Center for Traumatic Stress for Children and Adolescents at Allegheny Health Network. And finally, Joaquim Jenkins, who is a community health worker peer with Healing Hurt People at Drexel University's Dornsife School of Public Health. Welcome to all of you. So just before we get started with the conversation, just a reminder to the audience, following this morning's discussion, we're going to have plenty of time for Q&A, but you need not wait until then. So you can submit your questions throughout the event as things occur to you using the Q&A feature at the bottom of your Zoom screen. So with that, let's get our conversation started. So Ted, I'm going to turn to you first. Can you tell us about the genesis of Healing Hurt People and your decision to create what we now all know is the very first hospital-based violence intervention program in the state of Pennsylvania?
Thank you, Marie. Again, it's an honor to be with all of you and to share these stories, actually. I don't want to date myself too much, but probably in the late 90s as a physician in training in emergency medicine in Washington, D.C., I saw a lot of young people come through who were shot, stabbed, and assaulted. And then it just became the norm. And we would often, medicine is such that, and it still is, that we're able to treat people for their physical wounds and discharge them back into their communities, but not paying attention to the psychological wounds and those physical wounds that kind of stick with them and then marinate and fester in some ways, which breed about trauma, symptoms of trauma, which feed back into the cycle of violence. Now, I didn't know all that back then by any means, but what I saw was a challenge of young folks, the challenge of young folks cycling in and out of the emergency department, some being able to go home or back to their spaces where they came. Sadly, some died. And I asked the question when I saw a repeat person in the emergency department as a physician in training, why can't we just admit them? And at that time, it was, if it didn't hit a major organ, penetrate a bone or a blood vessel, this is still true, that patient is likely to go home. And so again, just trying to think through, and so for that, they weren't able to be admitted. And so just trying to think through what could or should be in place for our patients that are survivors of violence. I had an opportunity to, when I moved back to Philadelphia, I had the opportunity to do some focus groups with young people who had been victims of interpersonal injury, also with emergency providers in the city of Philadelphia, to talk about what is it, how is it that we can address this issue of violence among our communities. And sadly, it was a preponderance against our communities of color then and still is now. And so after I collected the information from the focus groups, and then just the influence and the information and experience from folks like Dr. John Rich, who had done some work in Boston around Black men who had been victims of gun violence, and then the work of Sandra Bloom, who had really kind of cinched how trauma plays a role in the lives of not just people that have been victims of or survivors of violence, but many folks who have experienced any type of challenging experience. And most of us have the resources to kind of get back into the norm of things. But when those resources are not enough, what is it that we can do? And that's when we started to develop and explore opportunities around what healthcare providers could do. And that's where we brought in the combination of evidence-based practices and care management to help the young people and their families who had been victims of interpersonal violence. I would say survivors. And it's not to, I want to make that distinction in that I do believe that, you know, folks that have experienced the loss of loved ones to violence are in need of services as well. And there are some services in place, thank goodness, like Every Murder is Real, Amir. However, just our slice of the pie, and there's lots of room for other services to be in place, but I feel our slice of the pie as healthcare providers in emergency departments or in trauma centers is to develop and identify young people or people in their families to provide those services of evidence-based practices, as well as case management.
Thank you for that, Ted. So just to clarify one point, you're an emergency physician and you were not providing mental and behavioral health supports for the patients that you treated for a physical injury. So tell us a little bit more about that. I assume when you say care management and case management, care management is broadly speaking, not just physical care, but you brought in mental and behavioral health supports and provided case management for those patients. Is that correct?
Sure. It's also realizing, I think in that focus group with emergency physicians, the realization is that we can't do everything. I mean, we are skilled at taking care of those physical wounds, and making sure we're skilled at doing that. But then there's a whole potpourri of other things that our patients would benefit from. Some institutions are resourced such that they have social work and social services in place, but given the temperature of this of healthcare, that's not always a resource that's available. And so recognizing and identifying that some of our patients would benefit from behavioral health resources that are in partnership or in collaboration with people who are experts in that space, as well as the expertise of care management through our community health worker peers as well.
Thank you. So, Judy, I'm going to turn to you because Ted is talking about, even though he's not using that language, trauma-focused therapies for young people who are violently injured. And you had been doing that work in a very different context in the 80s. So can you tell us a little bit about your, the reasoning and process for developing trauma-focused cognitive behavioral therapy in the 80s? And I'm assuming that did not grow out of young Black and brown men being shot and stabbed in inner cities, but something very different. So talk to us a little bit about that.
Thank you so much for inviting me to be part of this conversation. I'm honored to be here. And by the way, I'm not at the beach. I'm in Pittsburgh. I just like to look at the beach to be inspired. So actually, after I finished my child psychiatry fellowship, I was working in a clinic in inner city Pittsburgh with Tony Manarino. And next slide, please. We actually were seeing a lot of inner city Black and brown children who were being shot. We started a clinic primarily for children who were experiencing sexual abuse, and they also experienced a lot of other traumas, but because there was nowhere else for children who experienced community violence to go, they came to our clinic. And we saw a lot of children who experienced gang violence and other kinds of community violence, and often they came to our clinic too. So TFCBT was developed by Tony and myself, and also by Esther Deblinger, who was running a similar clinic outside of Philadelphia in Stratford, New Jersey. And at that point in the early 1980s, the diagnosis of PTSD had just been introduced into the Diagnostic and Statistical Manual, not really for children, but for adults. And so we were, first just trying to figure out what kinds of problems did these children have and how could we best treat them. There were a few very new treatments for PTSD in adults. And so we started, to look at those treatments and try to figure out how could we use what they knew in adults to be developmentally appropriate for children. And we also looked at what kinds of problems did these kids have, and started to develop them and evaluate them for these children we were seeing in our clinics. And because these kids had other kinds of traumas also, most of them had multiple traumas, including community violence, we extended those evaluations to other kinds of traumas, including domestic violence, community violence, disasters, war, traumatic grief, commercial sexual exploitation, and so forth. And we've always included diverse youth populations because those were the kids we saw. Next slide, please. So very briefly, TFCBT is a component and phase-based treatment, and it was developed to address the kinds of problems that children have and teens have after they experience trauma. And because it's for kids, we felt it was very important to include parents or caregivers because that's the context they live in. And because so many of these children had experienced traumatic deaths, we also included grief-focused components for those children. Next slide, please. So the basic components are just summarized by the acronym PRACTICE, which is not accidental because we want children and their parents to practice these components in between the sessions where we see them. And so this slide briefly summarizes what these components consist of. So the first phase is a skills-based or stabilization phase. Many of these children experience a lot of dysregulation. First, we want, and again, we don't just check in with the parents or caregivers. We include the caregivers in half of every session. We see them separately at first, and then we have several joint sessions where we see the kids and the parents together. And we help to, help them understand making trauma make sense because kids have a lot of different difficulties, often behavioral dysregulation related to their trauma experiences, and often not just the parents or caregivers, but also educators and the kids themselves don't, connect together. Why am I behaving this way with their trauma experiences? And people just see them as bad kids. So helping to connect those behavioral or emotional problems, their anger, their sometimes substance abuse or risky behaviors, to those trauma experiences is really critical. And then helping them develop skills like relaxation skills to address the physiologic or physical dysregulation they have, affective regulation skills for those emotional reactions such as anger and sadness. Often these kids are hurting themselves or attempting suicide, or hurting other people for that matter. And then the negative thoughts that go along with chronic trauma experiences. After they've developed some regulation skills, and again, the caregivers are also getting all of these skills, we go to the next phase, which is trauma narration and processing. In this phase, we help the youth describe their trauma experiences in detail. The caregivers are hearing that separately with the therapist in preparation. So it's speaking the unspeakable and making new meaning. Often these youth are very avoidant of talking about these experiences. That's part of a trauma reaction, and we help them master that avoidance so they're able to face those fears and face those experiences. And then in the final phase, they come together with their caregiver, share those experiences. And at this point, the caregiver is able to understand and support the youth, and they come together and engage in safety planning. Next slide. For those who have experienced traumatic losses, we also have grief-focused components, and this includes things like resolving any ambivalent feelings they have towards the person who died, integrating positive memories, and then enhancing relationships with the people who are still surviving. Next phase. Again, we have tested, next slide, sorry. We've tested TFCBT in many studies, including 25 randomized controlled trials. Many of those were done by independent groups across the US and around the world. And these studies have consistently documented that TFCBT is effective at improving children's PTSD symptoms, as well as a variety of other symptoms and difficulties that youth develop, including depression, anxiety, behavior problems, negative beliefs about themselves and the world. And although the caregivers are not the primary focus of the treatment, we have also found that the caregivers who participate in the treatment also experience significant improvement in their own symptoms, including PTSD symptoms, their own depression, and their effective parenting skills. And importantly, these findings cut across different types of trauma, including community violence, and ages, race, ethnicity, gender, different countries, different settings that it's provided in, and different modalities. Next slide. In the last 20 years or so, we have really focused our efforts on modifying TFCBT for different communities. Through our SAMHSA grant, we've been using the Institute for Healthcare Improvement to really work within communities and integrating feedback from youth and families and key stakeholders within these communities to look at what they need. So it's not just, evidence-based practice, but practice-based evidence to really, apply TFCBT for communities, including communities of color. And you see, this is not a comprehensive list, but for example, our most recent learning community was a 1.5-year effort to integrate racial socialization with TFCBT for Black youth who experienced racial trauma as well as other traumas. We really have used that feedback to develop useful strategies, and we have data to show that it's very effective. And we've developed implementation manuals for these different populations, and they're available for anybody who wants to look at them and use them. They're available at our certification website at tfcbt.org, and we hope that you will see these and use these. And again, thank you for inviting me. I look forward to our conversation.
Thank you, Judy. And thank you for debunking something that I assumed, which was that TFCBT was only recently applied to diverse and minoritized populations. It sounds like it was developed in that context, and it has, you know, cross-cultural application, and that's pretty long-standing. So you used a phrase, I'm going off script here, but I really liked it, and I'd like to use it, and I want to make sure I know what it means. You said practice-based evidence. Could you say a little bit more about what you mean by that?
Yes, that's not my phrase. It really is, you know, bottom up instead of top down. So instead of developers saying this is how you use the model, communities help us learn how do you implement this for what we need. And so we work, that's what learning communities are. We work within the community to implement the practice in their communities with their children for the problems they have. And that's what learning communities or learning collaboratives are. So for example, in that most recent learning community, Healing Hurt People was part of that learning community. And we, you know, use small tests of change. Anybody can do that. A youth can suggest it, a family member can, a clinician can, and say, you know, I don't like this information sheet. I need something that really talks about, you know, what I want it to include. And so the clinician can say, well, help us, you know, develop something different that speaks to what you want it to include. And they develop it and they say, okay, you know, how about we use this? And other teams within the learning community can say, well, we'd like to use that too. So they use that, they get feedback from other youth. And, you know, we use it, we see how it works, we get, you know, we change it accordingly. And then the learning community tells us, how is this working? That's just one example.
Right. And it's a really good one and a great segue, I think, into talking to Joaquin about his role as a community health worker peer at Healing Hurt People. So Joaquin, could you tell us, those of us who are not familiar with what a community health worker peer is, tell us a little bit about what your day-to-day work looks like. And I think Judy sort of forecasted some of why your role is important, but if you could talk to us a little bit more about that, that'd be great.
Sure. A community health worker peer is someone who has lived experience from some sort of community violence, be certified in the role to assist with families in case management needs, counseling, resources, things like that. I work for the Healing Hurt People in Philly. I'm stationed at St. Chris Hospital. I'm actually here right now. So my day-to-day is that I go down to the ER. We have two binders down in the ER. I go down there and see if any doctors put any clients MRN number, the name, date of birth, who they feel may qualify for our services. We also use a program called Epic here at St. Chris, to where I think is more easier. The doctors and social workers just find my name in the St. Chris system and just send me the client that way. So yeah, my day-to-day is normally here majority of the week. I'm here meeting with clients who come in, bedside visits. I'm like the first initial contact for clients who may qualify for our services. I was able to build great rapport with people here at St. Chris, like social workers, Dr. Taylor's a name that come to mind. Myself and my team meet with his residents once a month. And yeah, just get the word out that we're here to assist any families who experience community violence, witness it, or God forbid lost somebody due to those things, qualify for our services. So I go in, talk to them, of course, get to know them as a person for an icebreaker. I use my lived experience to gravitate more to the family and clients, because I'm from a lot of these communities the clients is coming in from, and just help them out the best way we can. To whether that's like, I help kids get their driver's license, driver's permit, work ready stuff. If they are interested in counseling, I'll pass it along to one of our therapists who's available, and just kind of just work with the family for like maybe about 6 months. So that's pretty much my day-to-day here. And also through Drexel, I've been able to be a part of more presentations like this, presenting to different organizations. I presented at several schools this year, talking with high schoolers. There was a high school here, Roxburgh, who was known to have a lot of bad shootings in that area. So I was able to go to the school earlier this year and talk to the kids about ways to stay safe, and if they may be interested in speaking to somebody or a team and things like that. So those are my day-to-days. I hope that answered your question.
No, that was a great answer. So it sounds like what you're saying is you're the bridge to the community that Ted talked about, not seeing in the initial phase of his work as an ER physician. So you bridge, but so you do work also, I assume. You say you present to schools and to young people, but a lot of your work happens in communities, not
Yes.
just in the hospital.
Mhm.
Got it. Okay, great. So Arturo, talk to us about, well, I'll back up a little bit. Your current research is on the impact of evidence-based trauma-specific practices on the mental health needs of young people who've been violently injured, and in particular, youth who are racial or ethnic minorities or identify as LGBTQ. Talk to us a little bit about that, and I also want to give you space to pull all of this together. Joaquim's work, Judy's work, and Ted's as well, and how that's relevant to what you're working on now as a researcher.
Thank you, Marie, and good morning, everyone. Thank you so much, Marie, Mark, everyone at the Stoneleigh Foundation for all your work, for sponsoring the event and making it happen. It's an honor to be here today with two dear mentors, Judy and Ted, and a wonderful colleague, Joaquim. Thank you, Maria. I'm going to try to now bring it all together and then talk about the research we are conducting. One of the things when it comes to Healing Hurt People that, as you said, was the first hospital-based violence intervention program in the state of Pennsylvania. As we evolved for the past 16 years, I was lucky to join 5 years ago. Currently, the way our program works when it comes to our pediatric services, right? We are consider ourselves hospital and community-based, as Joaquim said, because we go beyond the hospital, right? We use the hospital as a point of engagement and identification of cases, but I will say 90% of our services happen in the community, and I will define community in a minute. And there's 3 pillars to our services. We provide trauma-focused therapy. For children, we use TFCBT, of course. We also work with people up to 35, but we're going to stick to our pediatric work here. We also, Joaquim did a great job about describing the community health worker peer role, and also the third pillar is case management. Case management is delivered by both the peer specialist and our community intervention specialists, who are master level clinicians who provide also TFCBT. So I think one of the strengths of our model is the fact that we are very flexible. When it comes to the setting, we go, as I mentioned, we start at the hospital, but also we get a lot of referrals from schools and other child serving organizations. Our therapists and community health worker peers go to the homes, go to schools. We meet in the community, really wherever it's best for the client and the family, as long as there's privacy and safety. And we have 2 main office spaces. Joaquim is at St. Chris, and I'm here in Center City, Philadelphia. So we also offer that, and telehealth as needed. Our services on average last nine months. We work with people for up to 12 months on a weekly basis, but we can be, again, as flexible as the person needs, and sometimes clients or youth and their families choose to work with us once, twice, even 3 times a week. That's not, we really adapt to their needs. So in a nutshell, that's our Healing Hurt People today. And if we can go to the next slide, please. So for the next 5 minutes or so, I'm going to summarize some of the research we've been doing that I'm very excited to share for the first time with you all. And this is something that started with, I had been lucky to know John Rich and Ted Corbin for years before joining, and Judy Cohen also trained me in TFCBT 13 years ago. So a dream of mine was to join Healing Hurt People and the Center for Nonviolence and Social Justice and bring TFCBT as a potential EVP for our work, right? So we started that in 2018 when we, thanks to the Philadelphia Alliance for Child Trauma Services, our clinicians were trained and we started delivering trauma therapy So TFCBT with peer support and case management. So we got from August 2018 to March 2020, that's a retrospective study that we're conducting, or that we have conducted, that based on the gathering information from the electronic charts of our youth served ages 8 to 18. You probably see March 2020, because what we were testing here was home and community-based services, and COVID hit, so we have to stop for a while and moved quickly to telehealth. But during that year and a half, we had 155 children ages 8 to 18 who were referred. About 17% of them on the left side, either we were not able to contact them or they declined services. But really, a little bit over 80% or 82% of these youth received some sort of services. 50% received outreach services only, which includes what Joaquin was describing as peer support and case management. And about 30%, 32% of 50 youth received our full menu of services, which includes a 2-session mental health intake with then offering TFCBT. Next slide. And as I mentioned, which I think it's important, it's 82% of children utilized our outreach services or completed mental health intake. And a lot of times, when you talk about research, people will say, well, why, you had 155, only 50 received mental health therapy. What happened to the rest? And the truth is, as John Rich and Ted Corbin say so well, like no group is a monolithic group, right? So many of our youth and families told us, all I needed was for you to help me, advocate in school for my child, or reactivate health insurance, or help me, go to follow-up medical appointments. We're okay. This was great, like meeting with a peer specialist, someone from my community with like the same belief system. That was healing per se. I'm fine. We don't need mental health, right? 50 kids and families said, yes, we want mental health. And next slide, please. So this is a lot of information, but we just completed this study. But just to show you all we have the demographic characteristics. If you go to the right, it's the full sample of 50. The gender, 60% of the youth identified as male. The average age was 14, 50% Black, 46% Latino. Importantly, at least 24% of our sample were not US born in Latin America and the Caribbean. So our services are offered in English and Spanish, and also regardless of insurance status. The reason for referral, we see, and this is a trend in youth, right? When we talk about our adult population, usually the majority are due to gunshot wounds that are referred. When it comes to youth and adolescents mostly, the number one referral is blunt trauma, right? Physical assault that was severe enough for them to end at mostly St. Christopher's Hospital at the ER, but also 22% were gunshot wound referrals and about 14% witness violence. And something that's very important for us that we wanted when we decided to do this study is that we conducted a very thorough trauma history screening for youth. And you see how under the number of traumas, the average, the sample had an average of 7.2 trauma types, different trauma types, right? Which means that by the time they were referred to Healing Her People, they have already experienced 6 different traumas. So that's very important when it comes to like thinking about the developmental trajectory of the youth and how we implement, in the case of TFCBT, the application that's tailored to kids who experience ongoing trauma and adversity.
Arturo, can I interrupt you quickly? For those among us who are lay people, I think number of traumas speaks for itself, but can you give us a sense of the range of experiences that you would count as a trauma for a young person?
Yes, that's a great question, Marianne. Thank you for bringing it up. So we used the trauma history questionnaire, which has 23 questions. So you can answer yes or no to 23 trauma types. The most common ones among our youth were of interpersonal kind, including witnessing domestic violence, witnessing community violence, including shootings, traumatic separation from a caregiver, including due to parental incarceration or deportation for some of our Latino youth, and also sometimes child abuse. Those are some examples. Also, medical trauma was included, not having enough food or, meet your parents making ends meet, growing up with a parent with a significant substance use disorder or mental health disorder.
Thank you.
Yeah, thank you. Any other questions before we move to the next slide? Good. And just briefly, for the sake of time, these are the services that we provided. 60% of the youth were outreached by a peer. There were 40% who were not, and sometimes what happens is like the family wants mental health therapy directly, so in that case, they go straight to a therapist. Other times there was a need for, we have a wonderful Spanish-speaking therapist, actually two, so it went straight to the therapist in those situations. But mostly, Joaquim and other peers did the majority of the work. And even if they were not outreached by a peer, then a lot of youth, then they wanted to have the peer component as part of their treatment. Mental health intake, TFCBT, I'll be talking a little bit about that on the next slide. And one thing that I want to emphasize that we firmly believe in engaging the caregiver, engaging the family member, right? And in this case, TFCBT lends very well to the work we do, because as Judy mentioned, like everything the youth is doing during individual sessions, you're doing in parallel sessions with the primary caregiver, right? And we also wanted to briefly present this slide about, okay, how many sessions on average do we take? Because sometimes there's this myth, Marie, you were talking earlier about debunking myths, that when people have gone through so much trauma, therapy will last forever, and treatment has to, it's a lifelong experience. And we see here that for many kids, we were able to be pretty effective with an average of 14 TFCBT sessions, plus something like 7 peer support and 5 case management sessions. So I'm not good at math, but something like that's like 25 sessions that we met throughout 6 to 9 months or even a year with each child and family. And next slide, please. And we're also excited to report that we were very thorough with measuring outcomes. So we wanted for each child during the mental health intake to complete what's one of the gold standard for measuring child PTSD, which is the child post-traumatic stress symptom severity scale, which was our primary outcome. And we see how from pre-test, they showed an average of 34 points. 31 means full-blown PTSD. And it went down, you see the yellow arrow, to almost 17, which is subclinical PTSD. So we saw a very clinically and statistically significant improvement of both PTSD and then depression symptoms that were our secondary outcome, that went from clinical depression to subclinical. And next slide, please. So when it comes to research, we recommend, our study was a pilot study, was a real world implementation study, which we're very proud of. We understand it was not a randomized controlled trial. So, and with everything I think all the momentum that we have for peer role, it's important to have more research to really evaluate the specificity of what all that the peer support adds to the role. As Judy said, TFCBT has been evaluated, at least 25 randomized controlled trials. So I think we're fine there. And then conducting qualitative studies to really explore how people and young people help, their help-seeking behaviors and barriers to accessing services for racial and ethnic minority youth who are exposed to community violence. And the last thing I wanted to say, if are we okay with time, Marie?
We're good.
Yes, okay, thank you. It's that one question that people might be asking is like, why did you do this study, right? On top of the most important piece is like implementing, TFCBT with peer support and case management for the benefit of our communities. But why did we take all the time and effort to do a study? And this is because, to our knowledge, and both Judy and Ted were very involved from the beginning, this was the first time that we were evaluating TFCBT when delivered in a home and community-based setting, with the addition of the peer support. So we believe this application of this model has a lot of promise, and that's why we wanted to present the data to all of you today.
Great.
Thank you, Marie.
Great. So I'm going to ask a question, and I'd love each of you to answer from the perspective of your respective domains. And I'll start with you again, Ted. How much should we take into account race and ethnicity and other minority identities as a factor in violence intervention programming? Because one might say injury is injury, trauma is trauma. Why are factors like race, ethnicity, and LGBTQ status relevant in that programming?
Sure. Thank you for that question, Marie. I would say that, just in looking at the data, sadly, the preponderance and the high numbers are in our Black and Brown communities, more specifically African-American men. And so the question is, why has there not been more interventions or services put in place, given this, in so many ways, this epidemic of gun violence? And so I would say it does have, sadly, it does have a color to it. It's not to exclude others from any of our services, but recognizing that this is something that is and should be culturally appropriate, culturally responsive in how we deliver the services, how we interact with the patients or the clients. All that needs to be taken into consideration. And so I think you heard it in what Judy said as well. It's really important to incorporate issues of racial trauma. Those are very different from some of our other patients who have a different racial and ethnic background.
Right. And I'm inclined to ask Joaquim to speak to that as well, since you mentioned that, we're talking primarily about Black and Brown men. So Joaquim, in your role as a community health worker peer, does that, do you think, have any impact on your effectiveness in your work, enhancing or, detracting from your effectiveness as a community health worker peer? Issues of race and identity?
I would say that it's very beneficial for someone who looks like myself to talk with these clients, because from my experience doing this work, they're more inclined to open up, be more vulnerable towards someone like myself than CISs. And that, no disrespect towards them, it's just that, I think I'm trying to make sure I'm answering your question. Can you ask me the question one more time so I can make sure I'm staying on topic? I don't want to like go off.
Sure. So we've talked a lot about race and ethnicity in this work, and I was curious about whether in your case management that becomes a relevant factor: race, ethnicity, and potentially even in gender.
Yeah, I wouldn't say it's just, I think it's more impactful from my experience. I think the longest, just to share this for a moment, my longest bedside visit I had at St. Chris since working here has been 2 hours, and normally it takes like maybe 30 minutes to 45. And I think the reason was because, me and the client look very similar. We're from the same background, and I was able to like use, again, my experience from what I went through, and just to get to know the client on as a human. Like, before this happened to you, what you like to do, what was your hobbies, or were you into video games, were you into this and that? And then once I was able to do that, then the client just started like pouring everything out. So I hope that answers your question. So that's my answer to the question. Yeah.
No, it does. Thank you very much. And Judy, in terms of trauma-focused cognitive behavioral therapy, you mentioned that the practice was developed in diverse populations and settings and cultures. Is it still relevant, or is it just what it is at this point, and there's limited adaptation necessary to apply it to diverse populations?
I always have more to learn, and I think we continue to learn more. And one of the things we learned from this most recent learning community was that we needed to do a better job of asking specifically about racial traumas, because we weren't asking, and we needed to learn how to do that better. Yes, we were serving a lot of Black children, but if you don't ask, they might not tell you about these specific kinds of racial experiences. And many of these children said, "Thank you for asking. Nobody's ever asked me, if I had a Black therapist or a white therapist or, whatever. Nobody's ever asked me about these kinds of experiences, about being called names or encounters with the police or whatever." And so learning how to ask these questions, regardless of the race of the therapist, was really important for us to become more mindful about how to have these conversations. And parents were also, saying, "Nobody's ever brought this up." And some parents, it has to being racially sensitive doesn't mean you should be individually insensitive. And that's really important, because some families didn't want to focus on those experiences. Some kids said they didn't have them. We're really here to talk about the sexual abuse or the domestic violence, and that's really not what we want to. That's not what we're here for. So you have to let the family guide you about what's important to them.
Right.
And I wanted to just say something about intersecting identities. Anytime,
Sure.
as a clinician, I think anytime you want to help somebody in therapy, you have to learn about that person or that family. And I think we as clinicians need to be very humble and not assume that we know anything about what part of their complicated identity, and everybody has many parts of their identity, and not to assume that we know what part of their identity, be it race or ethnicity or religion or age or gender or sexual orientation or anything, is causing or the central part of their trauma experiences or their mental health problems. We have to find out, we have to ask them, we have to be good clinicians. And so in our clinic, we ask, is there any part of your identity that has contributed to your stress or trauma experiences? It's hard to ask a 4-year-old that, but you can ask their caregiver. And if they're old enough to understand what that means, we really want to explore that and understand that. And sometimes, you learn things that you didn't know about that. And I do want to just share with you all that in this learning community, we did find out that the intersection of sexual orientation and gender identity, we don't want to burden people with asking so much data that it's too hard for them to participate. So there's a balance in doing research, especially in communities that are already burdened, that they just can't do it. But we did ask about sexual orientation and gender identity, along with ethnicity, and of course these were Black children. And we found that Black youth who identified as being LGBTQ were much more likely, almost all of them completed TFCBT, compared to a substantially lower proportion of straight Black youth who were less likely to complete TFCBT. And, we can't say why that is, but it's possible that double discrimination or the burden of greater traumas may have led them to have higher need for trauma treatment. And we've got to explore that more. But intersectional, identities are important to understand. So it's nuanced. It's not just, okay, if you're Black, this is what you are, and that's all you are. So we really need to understand each individual person we're trying to work with.
Great, thank you. Arturo, before we move on, did you want to add anything to that question around race, ethnicity, other identities?
Yeah, I think everybody covered almost everything I could have said, and so well covered. I think, yeah, my answer will be that, yeah, of course, how do we see race and ethnicity? It's really important, and as Ted mentioned, in Philadelphia, it remains that the majority of the victims of gun and community violence, 80% are Black young men, right? And so having that as a clinician, as a program and institution, having the cultural sensitivity and competency to really sort of tailor your, treatment to the needs and the strengths and resources of Black communities in Philadelphia, it's very important. And, I know that's how the center was developed, the Center for Nonviolence and Social Justice. And at the same time, yeah, to piggyback on Judy's quickly, we also do a screen for sexual orientation and gender identity. And we know specifically in the city, trans Black women are victimized at these alarming rates. So I think it's both focusing on the importance of race and ethnicity as like an historical trauma and LGBTQ youth.
Right. And how recently have you done those screens around intersectional identities, and like when did that begin roughly? Is that new or?
Yeah, we've been doing it pretty consistently. I would say for at least 6 years or so.
That's great. Well, and the reason I ask that is in part to segue to my next question, which is around what trends you're seeing. And Arturo, Ted, Joaquin, you might be best positioned to answer that. What are the trends you're seeing among young people who've been violently injured? Because in many ways, you all are at ground zero, right? Joaquin's right in the emergency room. You, I'm sure, Arturo, see people very shortly after their most, acute physical injuries have been dealt with. So are there things that you're seeing on the ground, so to speak, that the rest of us might not be privy to yet? And what are the implications for those things in your practice at Healing Hurt People? Anyone jump in? Yeah.
I'm happy to jump in and start. I would say that I think what we know has proven to be fact is that unaddressed trauma and violence begets trauma, violent interactions, and in some instances, suicide. And so recognizing that is a known cycle, where are the opportunities for us to have an impact or make a difference? And what we've been doing and talking about here is one of those spaces, because it's been proven, though not the resources to study this work is not as accessible as we'd like it to be. But we know from some of the studies that we've done, some of the studies that Arturo has participated in, is that involvement in programs such as these decreases depression, improves sleep quality, decreases other trauma symptoms. And so realizing and understanding those, and those are big things that contribute to, daily activities. Knowing those things are true, it's information for us to realize that such programs should be in place.
So basically just the far-reaching effects of trauma where we might not have thought it might be. Great. Anyone want to add anything to that? Arturo, Joaquin, like what are you seeing? What are some trends you're seeing among young people violently injured that we may not know about as lay people?
I will say, for what I'm seeing, it's just the phrase hurt people is a thing. A lot of these young victims, not even victims, these clients I see, they just, it's like a lot of like embedded trauma. You know, a lot of things we normalize as Black people, we shouldn't even normalize. It's not normal. Like hearing gunshots or a loud noise. When I talk to these clients, they're like, "Oh, well, that's how it is." I'm like, "No, it's not. That's not. You know, it's not normal. It's just that's the fact that we think that is normal. That's the problem. A lot of feeling like they have no other choice, like no other options as well. I think that's another thing I'm noticing too, because when I work with these clients and I show them like, hey, this happened unfortunately, but this is not the end of you. This is like, you can use it as a stepping stone to get to you want to get to. And I showed them like different ways, like the resources, different opportunities. And then when they see that, they're like, oh, I never would have seen this before I had connected with HHP. So I think those to me is what I've been noticing as well.
Great. Well, let me stick with you a little bit, and if you could talk to us a little bit about this, how do you address or the stigma surrounding mental health care and seeking out therapy for those young people who are hesitant to do that? I imagine that's something you face, and what do you do to address that in your work?
What I do is that from what I've noticed, because I've been caught in this too until I got older and started doing my own work. A lot of my young men, the whole toxic masculinity is a real thing. It's like, oh, I can't talk to somebody, I'm all right, this, that, and the third. They think they go to a counselor, they feel like they're gonna get put like 302, we call it here, or get put away. I'm just like, well, just you have to talk these things out, because you keep stuff embedded in you, it will overflow, and the shortest thing that the smallest thing that happened to you, you flipping off. So I think when I let the clients know right away when I first meet them, I say, listen, I'm not going to force you to talk to a counselor, but I will recommend you talk to a counselor. You got a lot of stuff from what you told me. I'm not licensed to tell you. I can give you like advice from what I went through, but talking to somebody that's like in our department or therapists in general will be beneficial to them. And I've been met with a lot of pushback, but I think just being patient with them and just, talking with them a little bit and just, telling them that it's an option instead of like forcing them to like, oh, you have to talk to somebody. Because I have a lot of families who they be like, oh yeah, you got to talk to a therapist. And the child is like, I don't want to talk to a therapist. And I'm like, if I may, it's available if they want it, but at the same time, we don't want to make it seem like they have to do this, Then sometimes when clients do be open and say, all right, I'm interested in a therapist, I will be with them for the initial outreach. When they meet a therapist, I'll be right there with them. That way they'll feel more comfortable and vulnerable. And then once they have their own rapport with a counselor with us, they're good to go. I fall back and then kind of just go from there. And a lot of times too, the counselors and myself, we normally tag team working with clients. We'll do like community visits together, or they come to our office space together and things like that. So I think just being patient for me for what I can say to answer the question.
Yeah, I mean, I can certainly hear how that's different from someone getting a referral written on a piece of paper. You kind of walk with them a little bit into that process. I'm sure that's very useful. Judy and Arturo, some mental health providers are actually reluctant, it'll come as a surprise to some of us, to offer evidence-based practices to youth and caregivers. What do you tell those mental health providers who, have their own reluctance for whatever reason to offer those kinds of services?
Judy, do you want me to go first? Thank you, Marie, for asking that. To me, it's like always, we take a lot of pride in offering our children and families only the most effective services, so which means services that have been proven to work, throughout and across settings, and of course that are delivered in a culturally sensitive manner. So it's that important that when you work with especially underserved people who have been mistreated and a lot of times haven't had the opportunity to access the services that they deserve, like to make sure that we offer to them, again, what has proven to work and something that has a high likelihood in like helping them heal from traumas that they have experienced.
Judy, do you want to add anything?
Yeah, I want to start by saying that people who go into counseling or therapy, providing therapy, especially for children who experience trauma, are doing it not to get rich, not to get famous, but to help people. And, so they are altruistic, well-meaning, good people who are really trying to make the world better. And I applaud that. And so if I talk to somebody who is doing that work, I start by trying to understand, what are you doing now? And it's likely that it is working, that it's helping children, and that's why you want to keep doing what you're doing. And so help me understand what you are doing now. And it's likely that most of, a lot of what you're doing is effective, and it overlaps a lot with evidence-based treatment. So, so I want to start with validating and understanding what is it that you do now, what is it that you're finding that works, and what are your concerns about learning about or understanding what evidence-based treatment is. So instead of saying, being dismissive or being critical, it's really, it's parallel to therapy, really. It's like starting where people are, listening to them, understanding them, and validating that they really do have something positive to offer. And I should say that in our studies, we always wanted kids to get better. So we used the best of supportive therapy that was offered in the community, and kids did get better with that. That was our goal, for everybody who came to our clinic to get better. Families didn't come to our clinic to be on a waiting list or for their kids to keep suffering. And so we have evidence from our studies that what community therapists offer is good. It works. It's just that, we have something that probably works better for most kids. So we can say we have data showing that what most community therapists does is very effective, that it works well. And so we have a starting point to say that, yeah, what you're doing is probably really effective and it works well. We have some things that we could offer that could help you make it even better if you're interested. But if you're not, we're not here to twist your arm or to, I don't want to make you do something you don't want to do. I'm just curious about, what your understanding of evidence-based treatment is. There's a lot of myths about that it's going to be something terrible. It's going to be a cookbook. You're not going to be able to use your skills or your creativity or your connection with, kids or families, or your caring. And all of that is not true. So, addressing the myths and misconceptions about what evidence-based treatment is really important. And after we have a conversation, if the person says, I'm happy with what I'm doing now, I'll say, keep doing it, because you shouldn't do something that you're uncomfortable with. That's not likely to work. And, kids have a radar for somebody who doesn't like what they're doing. And why should you be unhappy? But after these conversations, I'll say that many people are, willing to at least learn about or hear about what this treatment is, and they see a lot of commonalities, and they may even be willing to, take a course or sit in on something, and they say, yeah, this is pretty similar to what I'm doing. There are some differences, and maybe I'll watch a video or I'll try it out, and they often become, big fans. Sometimes they don't. And if somebody says, I don't like this, I don't want to do it, I'll say, then don't do it. It's not a right fit for you. And nothing works for everybody. And that's fine.
If someone were curious, is there a central repository or some resource you would just off the top of your head direct them to? And if you can't think of it now, we'll certainly circulate that after the webinar. But just curious.
Sure. Our certification website is easy to remember. It's tfcbt.org. It has a lot of information. All of it is free. You can go to it. You can see our implementation manuals. You can see information. There are a lot of resources to download. You can look at as much or as little as you want. There are videos. There's, resources for implementing by virtually. So it's a good place to start.
Great, thank you. And Ted, I'm going to toggle back to you for a minute. I think a lot of folks on the webinar find really compelling the origin story for Healing Hurt People. And there may be some physical health professionals out there who are curious about the process of joining or starting a hospital-based violence intervention program. What are some words of wisdom or starting points that you might offer to them?
Yeah, that's it's interesting because we're actually in the process of implementing a program here at Rush. And one thing I think we did it back in Philadelphia, but what we're doing in this iteration is really listening to the community, largely in part because one size doesn't necessarily fit all. I mean, for the majority of the population that comes through our emergency department are largely adults. We do see a small population of children. We're not a level 1 trauma center either. And we partnered with some really amazing folks in our Department of Psychiatry and Behavioral Health Sciences who actually do, I would call the other version or a version of TFCBT, which is cognitive processing therapy. And a really, really brilliant team of providers and a community health worker. Like I said, we're in our nascent stages, but what we are doing, we've developed a community advisory board. We're doing some training for the providers, our nurses in the emergency department, our residents, our faculty, to get them to understand, to understand trauma, basic understanding of trauma. We don't have to go into the depth that our community health workers and our therapists know or are skilled in, but just to get them to understand, what someone could potentially come through. When you come into the emergency department, you're already vulnerable. And so we want to identify some of the other things that could be going on by connecting them to the resources. So it just, in my opinion, it's listening. It really is listening to the community to adapt it to what the community is asking for and what they need. Resources help. They always help. And I'm confident that there has been a recognition of this epidemic. And so there are resources both locally, regionally, and nationally for folks to explore. But I would also just get a sense from the community, even in the exploration of developing such a program is really important.
Right, thank you. Another element that I personally, I'm sure other people share this sentiment, find really compelling is just the notion of a community health worker peer. For any of us, never mind those who unfortunately were violently injured, the hospital experience can be really disorienting and bewildering. And having someone from the community sort of translate what has happened to you and what is happening and what you might avail yourself of after you've been in a hospital setting strikes me as really an invaluable resource. But having said that, there are some challenges recruiting and retaining community health worker peers. And so I wondered if Joaquim and Arturo, you could speak to those folks who might be able to recruit but not retain, or might have some trepidation about launching a community health worker peer program in their HVIP, or as a part of a plan to develop an HVIP. So around recruitment and retention, what are some of the thoughts you all had to make that a little bit easier and less daunting for folks? And either of you can go first.
I go first? Okay. So that's a really good question. I will say, for example, at Healing Her People and at the center, right? So we, the peer role started in 2013, so it's been 10 years. And the peer role and the community health worker peer has become a critical and key service that we deliver, right? And I think the importance of how you include young people, young professionals with lived experience of violence, but also that they have, and I think Joaquim, it's a perfect example of that they have the right skills to do this type of work. I think this type of work is very draining emotionally for all of us. And I think also when you have lived through similar experiences as your clients, that can be a strength, but can also be an area of growth, right? And I think it has to be the organization that it's welcoming peers and mentoring peers needs to have the right tools to help them succeed, right? And I think it's that ongoing learning. I think there's a lot of evolution that comes when you have such a strong peer component as you do. And so it's like both ways, right? Like you learn, they learn from you. And also being mindful of that, right? That I think it takes a lot of work, and Kim can talk a lot more than I can about this, but they go through very thorough training at Healing Hurt People. I think somebody was asking about motivation interviewing, suicide prevention and intervention, trauma sensitive interventions in general. So yeah, they're busy. They work really hard to be able to do the work they do, and hopefully we're also doing our part.
Joaquin?
Yeah, and if I can add to Toro, I would say one thing for me was when I was doing the training I'm getting old, a couple of years ago, you have to be willingness to doing the training, you're going to get triggered from your own stuff you went through. So I think being vulnerable, understanding that, you know what, doing this work, I got to do my own inner work so I can be able to heal other people. So that was one of my challenges when I first was getting my feet wet here. And also I will say just, I'm glad HHP doing this year, but having more people who actually have the lived experience and as a peer go to the sessions and teach the people that's trying to be in the position you in, because it's like you will learn better from someone that's in deep doing the work, you know what I mean? So I think that's big too. And just I will say just have like nice incentives for people that's interested in doing this work, because it is a lot. It's a lot of mental work. It can be mental. It's a lot of secondary trauma you're going to observe doing this work. I've seen a lot of cases where I'm just like, I got nieces and nephews this age, and it's triggering me. I need like about 15, 20 to get myself together. So I think just, having like these professional growth for Toro and Ted able, even if you're just going to school, because I'm interested in going back to school myself in the spring of next year. So having that opportunity for like tuition remission and things like that. So I think having like those kind of things that kind of gravitate to people like, okay, if I do this, it's a lot of work, but I'm getting X, Y, and Z. So it's kind of like, all right, let me try to see if I can do this. So I think I will say that for sure.
Great, thank you. And we're going to move into Q&A in a little bit. And so some things will come up organically. But as often happens in webinars, you're a panelist and you don't get asked the question you wish you were asked, so you could say the thing you really want to say. So is there anything that among you'd like to leave our listeners with? Any action steps, thoughts, closing remarks of any kind? I'm going to okay, Judy, thank you.
I actually have a question for
Sure.
my co-panelists, because I am so impressed with Healing Hurt People and the program and the peer support and the case management. My only question is, well, many questions, but how do you support it? I mean, our clinicians have to do case management, and any challenge, a challenge of any child therapist is, I don't get paid for this. I have to do this on top of everything else. And child therapists already have to do more work than adult therapists, and they don't get reimbursed for it. And so I'm really curious about, do you apply for grants to pay for this amazing, valuable work? Or, how can programs support this really, really important work?
That might be the most important question for folks in the audience. So I'm going to let both Ted and Arturo respond to that. I think it's super important people hear this.
Yeah, are you okay if I start, Ted? I think that's a great question. Thank you, Judy. And it's all about blended funding. I learned a lot from John and Ted about making sure you have solid funding that, it's both, we're able to get paid through Medicaid reimbursement. And we have, we're very thankful to Substance Abuse and Mental Health Service Administration, Community Behavioral Health, DBH, Springpoint Partners. So we also have funding that's more flexible that allow us to get paid and reimbursed for this very important outreach and case management work that traditional Medicaid reimbursement does not pay for, or for all of our aftercare services that we remain in touch with clients. So having this blended funding, it's key. And it's a lot of work, right? It's ongoing work, and showing our funders why is it so important that they remain committed to the work we do.
Yeah, absolutely. I think blended funding is a key. And there's a element of responsibility that our government should have. That's me speaking a little bit. And so advocating for some reimbursement for the services has been really, really key. Hence the ability to be able to bill Medicaid in Pennsylvania has been pretty unique. And so where are the commercial payers is the question. And so they're the next that we'd like to figure out where and how they could bring in some reimbursement for the services that are being provided. But again, it would not, the reimbursement that we are getting for Healing Hurt People services right now is pretty unique. But yeah, it does provide some core of funding. But Arturo is exactly right that it has to be, ideally, there's a blend of funds to support the work effectively.
So just quickly following up on that, Ted, do you really mean ideally there's a blend, or there has to be a blend in its current iteration to be supported? Because it sounds like you're saying it cannot, as currently configured, be wholly supported with public dollars. Public dollars just does not pay for this kind of work. So there sounds like there's a policy component. I'm always all about that stuff, but for folks who are interested, I'm sure there's lots of conversations to be had about why this is not publicly funded, when it seems like the evidence indicates that it's a necessary way of providing services and not just some cute flash in the pan thing, right?
Right. I'd also go, I mean, for years, I'm sorry, my internet's a little buggy. For years, the NIH has not funded research on gun violence. And so I think, again, we're in a space where there could be some difference, both from a, inquiry perspective, but then, we still need solid programmatic funding. And I think insurers are, if we're talking about improving health outcomes, insurers have to be at the table, not just our government insurers.
Got it. But in the interim, if there are foundations on the call, there's a lot of conversations to be had for supporting this work. So Mark, I think I'm gonna send it over to you to begin the Q&A, and then a little bit later we're going to hear from Ronnie Bloom, Stoneleigh's executive director. But Mark, for now, turning it over to you.
Thank you, Marie, and thank you all for all of the fantastic questions you've shared in the chat. We're only going to have time to highlight a couple just for anybody who's not been in the Q&A, or for people who will be watching this after the fact on a recording. So if you're in our audience, please scroll through those. There's several fantastic questions and answers there. To get us started, I know a lot of folks have asked about resources that all of our panelists have mentioned. The one I'll highlight right now is just the website, that's tfcbt.org. And all website links and other resources that our panelists have mentioned, we'll share all of that in a post-event email to you all, so no worries there. The next question I'll lift up, and I know, again, our speakers have answered some of these already. This is just an opportunity to elaborate if you like, or again, to reiterate for folks who are on the call today. First question comes from Carrie Krieger at Delta Family Services. It's a two-parter. Given that doctors recognize that they can't do it all, this is for Ted. Is there a suggestion, big or small, that you would give to us social services providers? And I think the second part of this is, what does Healing Hurt People know that social service agencies could use as a means to prevent violence?
So thank you for that question, Carrie. I think what we have moved toward is just some identification or recognition of some type of trauma symptoms that some of our patients' clients might be experiencing. I think starting there is helpful. I mean, the other piece is, okay, what do you do with it once you learn about it? And so it might be worth starting on the back end to see who's willing and available or accessible to provide some type of service, be it, again, we didn't start from the evidence-based practice. We knew there was something that needed to be done. We knew some social workers that had some skills around counseling and individual therapy. So that was our initial, but then we moved into the space of evidence-based and practice-based therapies for the patients. But having a team or a person who's equipped with those skills and then doing the screening on the other end might be a space to start in terms of identification and providing some service for our traumatized youth and families.
Awesome. Thank you, Ted. Arturo, I just saw you responding to this one question, so I'm going to lob it up to the rest of the panelists as well. Judy, you responded to this as well. This is from Elizabeth Wilson. What types of trauma are experienced by parents of trauma-impacted children and teens?
Yeah, and I think I second what Judy said, right? That sadly, data shows 65% of people will have experienced at least one potentially traumatic event. And when it comes to HHP and our communities, what usually parents report are exposure to community violence, surviving domestic violence, and different experiences when it comes to racism, and also traumatic separation, sometimes from their own caregivers. So a lot of times they mirror what their own kids are experiencing. And I think that's when it's important, like to think, when we think about breaking the cycle of violence, not only in the moment, right, to avoid retaliation, etc., but breaking the cycle of intergenerational violence, right, supporting families with that too.
Thank you, Arturo. Judy, anything to add?
Yes, just to add to that is such a, secondary prevention. If we can identify people who have experienced trauma and intervene and provide them with effective intervention, perhaps as Arturo is saying, as everybody is saying, we can prevent the longer term effects. And, obviously we can't prevent everything, but it's so devastating for parents who see, oh my gosh, this happened. I wasn't able to protect my children, and the same thing is happening to them. And I failed as a parent to protect my children. So we really, want to get people early and help them develop resilience to the greatest extent possible, so that this doesn't repeat generation after generation.
Thank you for that. And I think we have time for one more question. So let me pull one here. This one is from Radara. Apologies for pronunciation. This one's for Walt Keem. Given that we are talking about BIPOC communities, how has it been working in a hospital system, given the relationships with police and systemic racism?
It's a great question. If I'm being honest, it took me a little bit for me to get accustomed to working at St. Chris, because it's so much like down, especially in the emergency room, so much going on. So just that, and for the police as well. I had one bad encounter with an officer here at St. Chris when a client came in and he kind of just was interrogating me. I'm like, I work here. My badge is right on my shoulder. Like, I'm here to talk to the client. So I think even still, because I have to ask clients if for a lot of reports, like if police reports is made. And when I mention that, a lot of clients I ask that to, they get triggered a little bit. Like, I ain't going to the cops don't do nothing to stand the third. And then I have to explain more from my role, like, I understand how you feel, but it's important to have that documented, so that way, God forbid something else, if it gets any worse, you'll have that on your record, like, hey, you did make a police report, X, Y, and Z. So it's kind of on and off at times with that, I will say, for that question.
All right, thank you. And again, I know that we had several fantastic questions. If you have additional questions for our speakers, please contact us after the webinar.
Great. So Mark, I noticed that a lot of the questions folks asked were answered in the chat, just making sure everyone else knows that. You may not have asked a question because you were shy or you feel like there's not enough time, but your question may have been asked by someone else. So you can scroll through the Q&A and see the questions and the answers that were not answered live. And I believe at this time, I'm going to turn it over to Ronnie Bloom, Stoneleigh's Executive Director, for closing remarks.
Thank you, Marie. I'm Ronnie Bloom, as Marie said, and I have the honor of being the executive director at the Stoneleigh Foundation. On behalf of our staff and our board of directors, I'd like to thank this phenomenal lineup of panelists, Ted, Arturo, Judy, and Malkeem, for participating in this insightful and really timely discussion this morning. I do have to say kind of a special shout out to Ted Corbin. It's been such an honor to work with you over the years. We're still very sad that you decamped to Chicago, but we thank you for all of your efforts here in Philadelphia. We wouldn't be where we are today without you. All of you have provided us with really important perspectives, not only in the origins of healing hurt people, but also on how this intervention has evolved over time to meet the growing needs of young people who have been impacted by violence. We're so honored to count Ted and Arturo among our community of Stoneleigh Fellows, and we really appreciate the time that all of you have taken today to share your experience and your expertise with us. And many thanks, as always, to Stoneleigh's Deputy Director, Marie Williams, for her excellent moderation. Please stay tuned for more Stoneleigh-supported webinars in the new year, and be sure to sign up for our newsletter at stoneleigfoundation.org to keep up to date on the work of our fellows and grantees. And with that, I'd like to thank everyone in the audience for joining us today.
Thank you.